thanks so much for joining us today. I really appreciate it.
Thank you for having me.
Absolutely. It's wonderful to finally connect. So before we dig in, I'd really like to start with, I guess, a couple of things first. I know that you are a dental hygienist and orofacial myofunctional therapist.
Yes.
It's very hard to say for me all at once, which gives you an incredibly unique perspective. One, we really thought parents and medical professionals would like to hear. So one thing that I have heard you say before, I can't remember, I think it was an interview or a podcast, but if you can't breathe well at night, you're just not going to sleep well.
Mm-hmm.
And for somebody that really hasn't heard that before, that would be a great place for us to start. So, for parents especially,
Mm-hmm.
what does that mean? What is that impact? How do the two correlate?
Perfectly. So during the day, we go through our parasympathetic and sympathetic system. That means fight or flight or rest and digest. We're always switching between the two depending on what kind of events are going on in our lives, right? So
okay, right.
If you're running from a bear, your fight or flight is going to turn on. So heart rate goes up, blood pressure goes up, so you can run. And right after a meal, usually your parasympathetic system turns on, which is rest and digest, where all of those systems in your body are working with those functions that need to be done at that time. So usually you're relaxed, you're calm, your heart rate is low, your blood pressure is low. At nighttime, your parasympathetic is supposed to be on. So rest, right? You're resting. So you breathe in through your nose and you breathe out through your nose. Everything's calm. And like that, all of the magic things that are supposed to happen at nighttime can happen. All of these amazing hormone releases. You're going through every single sleep stage. Each one of those stages are very important for overall being and for you to get, getting healing sleep. So if you cannot breathe well, your body is under stress. If there's any type of obstruction, if your tongue is falling in the back of your airway, if you cannot breathe through your nose because you're sick and it's stuffed up, your body is going to go into survival mechanism. What is the first thing you have to do in order to survive? Is to take a breath. So your sympathetic system turns on because now you're under stress and you have to find a way for you to breathe. So instead of you getting healing sleep, your body's just trying to keep you alive. So your blood pressure is up, your heart rate is up. All of these things are happening. People start moving around a lot. Kids a lot of times will wet the bed, or adults have to get up to go to the bathroom, or there's excessive sweating. There's so many things going on because your body is just fighting for your life. So that's the importance of us being able to go into rest and digest and breathe calmly through our nose at nighttime.
So for parents that, and we hear this a lot, oh, my child's not a mouth breather, my child's fine. We tell them all the time, maybe, but go listen to your child sleep at night. It's kind of the stalker thing. Embrace it. Go sit there for about, 5-15 minutes, 3 times a week. Go and watch them. Go and listen. What exactly are they looking for when they go in there to do these little check-ins just to see?
Yes, usually we recommend going in about 90 minutes after the child has fallen asleep, because that will give you enough time for a whole sleep cycle to happen. We are looking for head position. So if the head is too elevated or too far back, what is the child doing in order to be able to breathe at night? We are looking for body movement. So limb movement has to do with low ferritin level, so low iron. So that would need to be checked out by a doctor. We are looking for some audible breathing or snoring. We're looking for drooling. We're looking for mouth open and tongue low. So there's, a conjunction of things that we are looking for to try to find out, is this child getting enough quality of sleep? Because you can spend enough time in bed at night, but that does not mean that you're reaching every sleep stage and staying in those sleep stages long enough. So of course, if we see lots of body movement, snoring, gasping for air, things of that nature, we would recommend a sleep study in a lab where we're going to be able to really tell what is going on with that child's sleep.
Okay. And if you see these signs and maybe you can't get a sleep study, let's just start with the first step. You go in, you monitor your child, you see these signs. Maybe they even have some additional in the morning. The sheets are just thrashed. They're everywhere. The child is groggy. They have a headache. Okay. That's a lot of signs.
Yes.
Where does a parent go? What's the next step? If we, can we go to a dentist? Is that the right place to go? Or do we go straight to the pediatrician?
I usually recommend calling a myofunctional therapist first. Why do I do that? Because we are the middle puzzle piece of the interdisciplinary team. A myofunctional therapist is connected with an ENT. She's connected with a dentist, with an orthodontist, with a chiropractor, an occupational therapist, a physical therapist. We kind of have, this whole team that we know who to refer to because we know the ones that are looking at all of these things. Unfortunately, in medical school and in dental school, all this airway stuff is not talked about enough. Tongue ties are not talked about enough. So all these things that we learn outside, it's not in there. So we got to make sure that we go to the right provider. And I will plug in here. If anybody's looking for a provider around you, we have a free global directory on Airway Circle. So if you go to www.airwaycircle.com, click on directory, and you can search by name, by location. You can search by procedure. If you're looking for somebody for a frenectomy or for a type of expansion, you can literally click the things that you'd like and increase the radius, and you're going to see anybody who's around you.
That's awesome. We'll make sure we put that in the show notes as well.
Thank you.
Knowing that it's so important, I mean, we always say we don't know what we don't know. Well, we know now, collectively we're learning, we're getting the message out. So with this knowledge, I mean, why is it still hygienists aren't taught this? Hygienists aren't given the time, in your opinion, to look for these things?
One, they're just so overworked and so busy. There are so many patients out there that just need cleanings and need, regular dental visits. They have to do so much already. I mean, we're learning about oral health, oral hygiene, how to treat periodontal disease. We are already inundated with all these things. What we are learning now is the hygienists are in the perfect position to go into this because we are inside the mouth every day. We know what tongues look like. We know which patients are difficult to clean, like little kids that are ticklish. Those are usually kids that don't keep their tongue up. Little kids that have tons of plaque on their teeth, that it doesn't matter every single time they come, they're full of plaque. Most of the kids are tongue-tied, right? Your tongue is supposed to clean your teeth constantly, all throughout the day. If you cannot reach those areas, you're not going to be able to clean your teeth. So there's so many things that hygienists are the perfect profession to start looking into these. Another reason is, of course, dental hygiene training. They would have to develop a whole new program to get these girls or these girls and guys through to be able to start looking at these things. And then the third thing that's a big issue are the boards. Dental boards don't know what to do with this information. They don't know what to do with us. Whenever we take our boards, we are training and proving that we are able to clean teeth, to be inside the mouth, to go underneath the gums, all of these things. But how would they be able to grade us and make sure that we know what we're doing when it comes to myofunctional therapy if there's no training in university? So there's still a big gray area. And of course, we are all working so hard and working together to move the field forward. And we are going to get there, I believe, eventually. I don't know how long it's going to take, but I'm here for the ride.
Same. Yep. That's why we're all doing these podcasts and sharing this information. So let's talk about oral habits specifically, this is something we don't talk a lot about on here and probably should though. Things like thumb sucking and long stage pacifier use. How are these signs of airway dysfunction or a tongue tie?
So we have nutritive sucking and we have non-nutritive sucking. So babies, when they're first born, they all tend to suck their thumb, and they're learning how to swallow that way in the womb. All of them do it, and it's normal and it's fine. But after a certain amount of time, if they need to do it, we start looking for other signs. Do they have any type of airway obstruction? Stuffy nose all the time, always sick, difficulty breathing through their nose, enlarged tonsils, enlarged adenoids. What do their teeth look like? Do they have enough room for their teeth? Do they have an open bite? Those are all reasons. If there's a small airway or difficulty breathing through their nose, kids are more likely to need a pacifier or a thumb inside their mouth, because that's going to open up the vertical, we call it, open up the teeth a little bit, which is going to open up their airway and make it easier for them to breathe.
Okay.
So of course there are consequences to prolonged thumb sucking or pacifier use, and it's just going to keep getting worse. And in terms of the teeth moving and causing more malocclusion or crooked teeth. But we have to ask ourselves why first. Is this a child, for example, that eats a lot of dairy? Dairy is inflammatory. And then they're always sick. They always have secretion. They cannot breathe well. They have to open their mouth. You know, we have to figure out what's causing it. But in the beginning, in the early months, it's totally normal for kids to suck their thumb. We actually do not recommend replacing it with a pacifier. If they suck their thumb and you're breastfeeding, we usually recommend continue breastfeeding on demand, and most children will stop thumb sucking on their own.
Okay, if they're breastfeeding and they don't have a pacifier.
And yes, that's why we say if they're sucking their thumb, just keep it's more natural. They already do it in the womb. Pacifiers, of course, there's different shapes. None of them are really great for orofacial development. But if your child needs, well, no, the kids need to suck to calm down, and you know they need it. So if there's no other way, go ahead and let your child have a pacifier, but try to keep it only when they need to calm down or whenever you're putting them to bed. After they fall asleep, you can take it out. So just reducing the amount of time, so the frequency, the intensity, and the amount of time that they're having that sucking habit.
If we have to go the route, or we choose to go the route of a supplemental pacifier, are there better ones, like, you know, like the Myo Munchie kind of realm of oral?
Yes, we actually recommend a lot of kids who have a pacifier to switch to the Myo Munchie, start doing a Myo Munchie instead. There are so many pacifiers out there. I think the best one right now is called the Nehme pacifier. It's very soft. And you can kind of see it whenever the child is sucking on the pacifier. You can see the tongue movement, but the portion that goes inside the mouth, it's very soft. The softest one, I think, out there. It's still not perfect, you know, it is completely round, and it kind of blocks the nose a little bit. So it would be ideal if they opened up a little room for the nose. Hint, Nini, if you do that, let me know.
We'll make sure we put a link in there for the Nini, the way it is now. And what's the difference though? I mean, the Myo Munchie though, my understanding, and maybe you could add to this, be great. It's soothing, but it also helps with their oral facial growth, right? Because we're all about growing the face out.
Exactly. And the way that it helps with soothing a little bit is because they're chewing. Every time you chew, we're releasing all those feel-good hormones in the brain. Whenever you're sucking, you're also releasing all those feel-good hormones in the brain. So there are different ways that we're soothing the child. But the chewing, so pressure builds bone. The more you chew, the more your face develops. There's a reason why children nowadays are not developing as much as they used to. And it's because we have changed the way that we feed them, right? After
Soft foods.
industrialization, we have soft foods, we have pouches, we have baby food, we have, I mean, kids eat mac and cheese, chicken fingers and French fries, peanut butter and jelly. They don't need teeth to eat anymore. Back in the day, we're giving our kids chicken bones, right?
Right.
And parents would give the kids whatever they were eating. They wouldn't blend their food and cook it differently. And don't get me wrong, I was extremely proud when I got a baby blender for my firstborn and made all her food at home, you know? But now we know better. Kids need to chew. If they have an issue chewing, if they're not chewing properly, if they're choking easily, then of course they need to see a feeding therapist. But kids need to chew in order for it to grow. So the Myo Munchie really helps that. The Myo Munchie also helps with proprioception. So feeling things around in the mouth. If the child always has the tongue low, the tongue is not used to touching everything, right? And we need the tongue to touch all the way up there. So the Myo Munchie usually will help increase that proprioception around the gums and the roof of the mouth. And the tongue will stay in the roof of the mouth, but it will help with the proprioception and nasal breathing, because you cannot have that in your mouth and breathe through your mouth. And it also promotes sleep closure. Okay.
But they don't sleep with it, correct? It's literally, it's soothing, it's chewing, and then take it away.
I have not had my patients sleep with it. Some practitioners may recommend that. And there's also a couple other devices, the Myo Brace and the Healthy Start. As the practitioners a lot of times will recommend sleeping with those devices. They're a little bit harder. They are not as soft as the Myo Munchie. And they're more of these growth guidance appliances. None of these appliances really expand the patient. They promote the tongue being in the right position. They promote nasal breathing. And with that, we see changes with the occlusion.
So growing the face out again is our goal.
Well, right? Growing the face out and sideways. We need to grow in all directions, really.
Right, but just not back.
Right, yes, right. That's true. But these devices will help you with the nasal breathing and with the chewing and the tongue position. They do not act like an expansion device. Like if you go to an orthodontist and they put a device on the roof of your mouth and you have a little key to really expand your jaw, it's different. You don't, if somebody's so deficient, they need so much growth, I don't usually recommend going with these devices. These devices are usually for younger children, that you cannot find an orthodontist around you to treat the child yet, but it's correcting habits with myofunctional therapy. Very important to do myofunctional therapy with any of them.
Yep, which is huge. So one of the things, as I understand it, is an open bite is a sign of an airway issue. So if you have a child presenting that way, what are some things you would do when working with them to help start the process of correcting this?
First thing I would do is nasal hygiene. Second thing I would do is nasal hygiene. And the third thing I would do is nasal hygiene. You gotta clean that nose. I tell all my patients, every single time you brush your teeth, you blow your nose, because we need to make it a little bit more common for us to do that all the time. You got to get used to cleaning your nose and using your nose. So blow your nose every single time you clean your teeth. They should go hand in hand. At nighttime, whenever they take a bath, we can go ahead and get the nose, throw warm water in the nose and get them to blow. I always tell them, pick your boogers out, get all that stuff out of there. And then we can do some nasal sprays, saline nasal sprays, or Xlear has a great product also that you can spray the nose and blow, massage the nose on both sides, just getting the patient used to using the nose.
Okay. All right.
Because if it's an airway issue, open bites are not caused by tongue thrusts. Open bites are usually caused by an underlying condition, usually breathing or something else. So we got to address breathing first, always with every patient. ENT appointment would be great to make sure they don't have anything enlarged. They scope the nose, put a little camera inside the nose so they can see the adenoids. If you're a parent listening, always ask for the degree or the percentage of obstruction.
Okay.
How obstructed is my child? Because a lot of patients will come back and say, oh, the ENT looked and they said it's fine. Well, what is it? I'm not sure. They said it's slightly enlarged. Well, what does that mean exactly? Give me a percentage, out of 100%, how much of it is obstructed? Because it's going to make a difference whenever we decide what kind of treatment to go with for this child. I usually say if a patient is obstructed 60 or 70% or more, and they have sleep apnea, that's when I recommend ENT treatment first. The ENT would recommend either tonsils and adenoids removal or steroid spray or something like that.
That's a pretty significant blockage.
Yes, it is. And of course, we all know that expansion now, a rapid palatal expansion that we call RPE, can reduce the size of tonsils and adenoids, but it is long-term. It takes some time for that to happen. And if a child has sleep apnea and they are lacking oxygen every single night, it may be too long for us to wait. I'd rather get the child breathing well first. So whatever we gotta do, I've had some patients that we recommend, okay, I don't recommend doing Flonase or some steroid spray for a long time, but if you guys wanna do expansion first, while you do the nasal spray so that child can breathe while we're doing expansion, let's do that. Because as soon as the patient is expanded enough, usually nasal breathing gets better because you're increasing the size of the nose as you're increasing the size of the roof of the mouth.
Which makes total sense. Absolutely. So when you're looking at a child, the child comes to you for the first time and you're evaluating them for a tongue tie. It's my understanding you can't always just see it. That's how they're going unnoticed. So what are 3 things that you look for when you're evaluating a child?
For a tongue tie. So number 1 is opening the mouth wide open and lifting or elevating the tongue without closing the jaw. So if they can elevate and almost touch the roof of the mouth, that usually means that they have good mobility, right? They can go all the way up without closing the jaw. If they have to close the jaw every time, that's a problem. And then we also look for the floor of the mouth. That's elevating a lot. That can be a compensation of those muscles to try to get the tongue to move. Another thing that I look for is for the jaw movement. So then I'll ask them to go side to side, put the tongue from one corner of the mouth to the other corner. If the jaw is going with it, that means that they may have a restriction, and every single time they move their tongue, they have to move their jaw because they're so restricted. And then the third thing that I look is function. I want to see this child chew and swallow because it's one of the most important functions, right, that we do with our tongue.
Right.
And most of these doctors, whenever they're looking for a tongue tie, they actually are asking the children to stick their tongue out. That doesn't really mean anything. There are plenty of kids who are tied and they can stick their tongue super far. But whenever you ask them to actually chew food and swallow, it is a mess. There's food coming out. They have to keep their mouth open. They cannot lateralize the tongue to move the food from one side to the other. Whenever they swallow, they are not forming a good bolus in the middle of the tongue. The food is all over the tongue and they cannot swallow almost everything with one swallow, only. It kind of stays a lot of stuff behind. So these are things that we're looking for whenever we are evaluating for a tongue tie. That's why a picture does not really
doesn't work. And that's
that.
fascinating to me too, because I always thought that one of the things, stick the tongue out, see if they can do it. So that's really interesting.
And the reason why they say that, it's because in medical school and in dental school, dental hygiene and speech pathology also, whenever we learn about ankyloglossia or tongue tie, it's that ankyloglossia, which is the full tongue tie. When the frenum, that little tissue underneath your tongue, attaches to the tip of your tongue. So most of those patients cannot stick their tongue out past their lower front teeth. Okay.
Okay.
But now we know that there are several different severities of restriction. Some tongues are super restricted, like that full ankyloglossia, and some have more of a posterior restriction. It's the back of the tongue that cannot elevate. And that will affect
Got
your
it.
swallowing. Those people that
So they
swallow
can
air all
stick
the
it
time.
out, but they can't
Mhm.
put the tongue flat in the mouth, for example.
Exactly. Yes.
Oh, that's interesting. Okay. Okay. Another thing that we've talked about in some previous episodes, we've talked a little bit about, cavities, specifically around sealants. And I'm not going to make you talk about sealants. But I do have a question because, you've heard it around the PTA, and we're all hanging out talking, and we're talking about kids. I have a cavity. I'm not worried about it. That's just a baby tooth. It's going to come out. But that's kind of a big deal. And as parents, we're not taking that as seriously as we should.
Yes, I mean, I think that we should ask ourselves, well, why do siblings, right? We have all these siblings. Why do some of them have tons of cavities and the other ones do not? They're pretty much doing almost everything the same. So there's a lot more to decay than we know. I feel like there's a whole new conversation now around gut health, vitamin D deficiency, vitamin K2 deficiency, making sure that the kids have enough nutrients. Of course, sugar. We all know about sugar, but also any types of foods that stay stuck in your teeth, like goldfish. Goldfish is awful because it really stays stuck on all these kids' teeth. It's not sugar, but it's carbs.
Yeah.
Carbs is sugar. So there's so much more that we're not aware of. It's not just about brushing and flossing and using fluoride. It's not just about how much sugar a certain child eats, It's the same thing, the frequency, the length of time that he actually stays on the child's teeth. If they, of course, how well they do their oral hygiene, all those things. But then again, mouth breathing. Whenever they're mouth breathing, everything dries out. And some of these cavities really like the dry air to form cavities a little bit faster. The saliva is there to protect those teeth. It has tons of things in it that protects those teeth from decay. So if everything is super dry all the time, they're more likely. Those kids that have tons of cavities on the upper front teeth, we always got to look for a lip tie, because a lip tie keeps the lip really close to the teeth and stuff gets stuck in there and you can't clean it out. So again, it's the how long does the food touch the teeth, right? So if it stays over there for a long, long time, it's more likely for that tooth to dismineralize and break down. It starts at those white spots. Those white spots is the first sign of cavities.
And the not only does it have those issues that you have to be concerned with, but there could be long-term health implications, correct? I mean, even though they're baby teeth, this could set up a child for some bigger issues down the road.
100%. So the baby teeth are extremely important because they are going to guide the adult teeth on where to go. If you lose a baby tooth too soon, then the adult tooth is more likely to come in crooked, come in the wrong place because it does not have that guide. Also, it's more likely to lose space because those teeth are always, they want to touch things, right? They always are looking for a friend to hang out with. There's nobody around them. They're going to go look for the next one. So they move and they're going to close those spaces if you're, you lost a baby tooth way too early. So definitely you want to take care of those, keep them as long as you can. Kids are more likely to develop correctly and have their adult teeth come in without any crowding if we keep them.
Awesome. So I guess I'd like to shift gears a little bit, and this is definitely just a matter of opinion, but you're in the field and you're seeing it firsthand. So where do you see the role of the myofunctional therapist growing and moving to and incorporating in these, like you mentioned, you're kind of in the middle of these cross-functional groups over the course of the next couple of years?
Oh my goodness. I see, and I am hoping for more awareness in not only the medical community, but also the parents and schools. If more people understand exactly what we're looking for and what we do and how important that is for child development, I really feel, myofunctional therapy is not a true profession. It is a modality that is practiced by mostly dental hygienists and speech pathologists.
Okay.
But I would love to see it as a true profession that, it's a specialty that speech pathologists and dental hygienists decide to go into, and it becomes a true certification through, with a federal board and all of that, because it is just that important. I mean, we're all doing these things all the time. We're all breathing, we're all chewing, we're all swallowing. We all
Right.
need the orofacial functions in order to grow and develop and be well. So I'm just really hoping that more awareness comes out and more professionals start collaborating with us, and more parents are seeking the help of a myofunctional therapist.
And I think that last one is huge. And granted, I'm a little biased as a parent, but I really wish I had known.
Right.
Again, you don't know what you don't know, but I
Mhm.
wish I had known about myofunctional therapy when my children were younger, because I'm doing research now and I'm speaking with professionals such as yourself, and just the impacts it could have
Mhm.
on a child's health span. It's astounding to me.
Mhm.
Absolutely astounding.
My dream would be for every dentist, every orthodontist, every pediatrician, and every ENT to have their myofunctional therapist. They don't have to work in the office, but have the person who they work with, because these patients are going to go back and forth. You can't, and the reason I always say, the reason why myofunctional therapy works so well, it's because we're never just doing myofunctional therapy. We're sending these patients to the ENT. We're sending these patients to orthodontics. They are doing, other treatment modalities, and that's why it works. We are treating the whole body. We're looking at the whole picture. We're looking at the whole patient. We're not just treating the orofacial muscles. That's how special the myofunctional therapy therapist is, because we're constantly learning. We are part of study clubs. We have weekly webinars on Airway Circle that we usually get about 70 people live every single week, and they're all there to learn more. So we're always, we got to find out how can we help these patients better. So we need to learn from other professionals. That's what Airway Circle is. I want to learn what an IBCLC, which is a lactation consultant, what are they looking at? What is an occupational therapist looking for? Can a child crawl with both knees? Both of my kids only crawled with one knee. I thought was the cutest thing. Well, it's a problem. But until I learned that from an occupational therapist, I didn't know.
How would you know?
That's a problem.
How would you know?
So that's the importance of the myofunctional therapist. They have the knowledge. They have a little bit of knowledge of every single specialty, so they know when to refer. And if you go to an ENT, they're not necessarily going to refer back to myo.
Right. Which hopefully that will change. And I'll make sure to put a link to that as well. So hygienists and other myofunctional therapists listening today can join in on some of your webinars.
Yes, we have a membership with Airway Circle, and we offer weekly webinars. We have a research folder. We're fun. So we have giveaways, and we have fun meetings that we do, but it's not only for myofunctional therapists. That is our biggest audience, but we have the whole interdisciplinary team. We have many dentists and speech pathologists and ENTs that come in and hang out with us, and we all learn together.
As it should be, right? And I know, I'll give him a plug. Dr. Bill Harrell is one of your biggest advocates. He absolutely adores your work and what you guys are doing, and is a huge advocate for you guys.
It goes both ways. We love it.
Yeah. So at the end of every episode, I like to hand the floor back to our guests, because you are the experts. You're the ones everyone's here to hear. So what final thought or message would you like to leave for our parents or other professionals?
For parents, if you're learning this information now, breathe. It is okay. Your child is going to be okay. You're finding this out at the right time. A lot of us feel so guilty whenever we find this information. Oh my goodness, my child is already a certain age and I've missed all these things. It is okay. You are always, every single day as a parent, you're doing the best you can with the information that you have. Well, now you have good, newer information. Let's just do the best we can with the new information. Take one step at a time. The myofunctional therapist, your myofunctional therapist, is going to hold your hand and guide you through the steps. For professionals, keep sharing, keep collaborating, keep reaching out to other colleagues and invite them to come join us because we need more. There's just not enough. There are not enough professionals out there to screen these patients and to help treat these patients. So if you can, call one of your colleagues, somebody that you went to school with, and ask them if they've heard of this. Share a podcast episode, share a YouTube video or Instagram video that you've seen, and invite them to join in one of the lectures. We gotta all help each other out so we can help more patients.
Well said. I could not have said that better. That was fantastic. Thank you so much for being on today and sharing all this amazing information. I really appreciate it.
Oh, thank you so much for having me. This has been a pleasure.